What is palliative medicine, and how does it differ from the traditional idea of what healthcare is?
Yeah. I'm both a geriatrician and a palliative medicine physician. And palliative medicine really focuses on a patient's symptoms. So it could be going on at the same time as you're trying to cure a disease, or it could be near the end of life where you're not trying to cure a disease, but just focusing on their symptoms. So someone might have cancer and they might be getting chemotherapy or something else, surgery, but they may at the same time, until all of that is, gotten smaller or treated, they may be short of breath, or they may have pain, or they're, worried about kind of, their loved ones, how they're dealing with all these symptoms. And so palliative medicine tries to focus on those symptoms, and it doesn't matter if they're being treated, curative treatments or not.
Interesting. So what caused you to go into this line of work?
So I knew I wanted to be a primary care physician when I was in medical school, and I was interested in geriatrics. And I actually, when I trained, palliative medicine wasn't its own specialty. So as an undergraduate, I was interested in ethics, medical ethics, and I had actually done a lot of reading and research and some papers on kind of ethical issues, many of which ended like end of life or other general ethical issues. So I was interested in the ideas, but for me, going into geriatrics was the way to do that. And so I did a residency in general medicine, and then I specialized in geriatrics afterwards. I realized that I like primary care, but what I really like is the intermingling of the medical stuff and all these other factors, like the family is important, or if you don't have the money to buy your medicines, all those other pieces are important. You don't have the ability to get out of your home to come in to get the treatments. All of those I find kind of interesting, and like not creating a cookie cutter, like, okay, you have high blood pressure, you need to take this medicine. I really liked, okay, you have high blood pressure, but you can't even get out to get your medicines delivered to you. And so how do you make all that fit together? So that brought me to geriatrics, and then kind of palliative medicine is kind of for me, was kind of a subset of that. And I, today that's its own specialty, and I was able to, take the boards in that as well.
Yeah. So we know that you're really specialized in home-based healthcare. So how has that kind of ethical viewpoint of it really worked into this kind of healthcare?
Yeah, well, you see it in real life, right? So when you come to the doctor's office, you have taken a bath, and you come in like looking the best you possibly can, and you may not, as the physician in an office, see everything that's going on, but it's hard to hide that when you come into the home. So if I walk into the home and I can smell urine, or I can see this huge pile of laundry that no one's been able to wash, I really right away kind of realize, okay, something's not going well here, right? Either they have a problem with their bladder, or they don't have enough help to do their own laundry. They're too sick to be able to take care of those things. And you can see that like immediately as you walk in, and you can start to ask questions to figure out, how you can help somebody.
So you touched on this a little bit before when you were talking about medicine and the cost, but is home-based healthcare affordable for most populations?
That's a challenging, that's like a big question, to be honest. So at Mount Sinai, we don't do this as a concierge practice. So we only do home-based care in our primary care program for patients who are homebound, who need it. If you can come into the doctor's office, it's not economically worth it for us to go, and you should come in. We're not doing this out of convenience. There are practices that do that, just like you can get everything delivered to your home today. Like you can get a doctor to come to your home, but it's not, you have to pay out of pocket for that. So we only do it if someone actually needs it. The way that healthcare reimburses doctors, like per visit, doesn't actually cover our costs. But the way we are helpful is we try to prevent other problems. So the biggest costs in healthcare are someone being hospitalized. And so if we can do a really good job and doing preventive care in the home and avoid them coming to the hospital, that's really our value. So it's not this like, you don't see it right away, right? It's not that we're bringing in all the money to take care of these patients, that we're avoiding all these other costs.
Thank you. So what is your hospital at home program?
Yeah, so hospital at home is even a little different. This is pretty new in the United States, hospital at home. Hospital at home has been around internationally for a while. In fact, Australia is not building more hospitals because of it. But in the United States, it really started in the mid-90s, and it's not really proliferated until very recently. So what we're doing is we are replacing what you would get in the hospital, but in the home. So these are, often elderly, but not exclusively. People who come in, let's say you have a pneumonia, need to come into the hospital for IV antibiotics, some oxygen. That's what we can do in the home. So we send a nurse twice a day to the home, a doctor sees you once a day at home. You get your IVs, you get oxygen, we do labs at home. And just like you might be in the hospital for 3 or 4 days, we take care of you for 3 or 4 days at home. So it's, in the United States, it's pretty new. We've been doing it for 5 years now, taking care of about 1,000 patients.
Wow. So what prompted you to create a program like this? And how do you determine what kind of patients are included within it?
Yeah, so it really came out of my work of doing the home-based primary care that we talked about in the beginning. So I've been in people's homes and I'm just like, oh, you see someone, you're like, you did a chest x-ray at home, you're like, you have pneumonia, but I can't get you nurses twice a day. I can't get you an IV right away and a nurse to give you, all those things. None of that's coordinated here in the United States to be able to just like, I need all of that right away. And so the default had been to send the person to the hospital. And so, that gets so frustrating as the doctor because you're like, I know I can do this. I know what antibiotic to give you. I know you need this much IV fluids, but I can't get all the logistics in place and there's no one to pay for all those logistics. So it's kind of that frustration that actually made us push hard for this model. We were fortunate. We didn't create it. As I said, it's been done in other countries. But when we started, we got a very large grant from Medicare. So they gave us almost $10 million to start the program here and get a lot of data to be able to kind of inform moving this forward. And so having that large grant helped us get started with our program.
Are any of your patients within the program having Alzheimer's disease?
Yeah. So with both programs, and I would say even more with the home-based primary care program. So about 60 to 70% of our regular home-based primary care patients have a dementia. And as you know, the majority of dementias are Alzheimer's. So you're right that many of our patients have Alzheimer's. That's one of the things that makes every other disease complicated, right? So if you have had diabetes in your life, or you have high blood pressure, or maybe you've had a cancer, but now you are 85 and you happen to also start having Alzheimer's with those other diseases, it's just kind of compounded the complexity for us to take care of you. Because, we prescribe it, you forget to take your blood pressure medicines now, for example, and then because of that, you might have had a stroke because your blood pressure is not controlled. All those things kind of compound on each other and make it more complicated and challenging for us to take care of patients.
So you're probably pretty familiar with the crisis of care, and how has it really affected your line of work in terms of like decrease of geriatricians like yourself, increase of patients with Alzheimer's?
Yeah, I think it's a combination of a lot of things. So first of all, I think there's a big crisis in direct care workers. So families, puts amazingly how much burden this is on the families. They want to take care of their own. It's not, out of any sort of, but you, let's say you're the daughter taking care of your mother who has Alzheimer's, you probably have to work too, right? So then what are you going to do during the day? And then can you be every night and every weekend always available to your loved one? That's a big strain. And so then the alternative is hiring someone to help your family member, and that costs a lot of money. And so that's a big problem to start off with, is that whole caregiver element of Alzheimer's. And then you're also right that then on the medical side, although it's getting better than it used to be, we're never going to have enough geriatricians. It's not a field that people find super exciting and super sexy as you're trying to, you're going through medical school. You find oh, orthopedic surgery sounds so interesting, or dermatology. Those things are, what draw people in. And although we should try to think about that problem too, what's really helped, I think, recently is that many medical schools and residencies are trying to get basic geriatric training to everybody. It doesn't have to be only a specialty, but if every primary care doctor, every orthopedic surgeons, one of their big things they do is a lot of hips and knees of patients who are geriatrics. So they need to know about geriatrics too. So giving them those training is really one of the big pushes right now, is kind of making sure everyone knows some really key elements of geriatrics as they train, for nurses, doctors, social workers. That will help this, but we're not there yet. It's not in every medical school, it's not in every hospital yet, but there's a lot of movement towards that.
Great. So how does your program account for the families? Because I know that you touched upon that earlier.
No. So first of all, we're in the home, right? So we're meeting the families. I mean, a family could come into the office with their loved one too, but I think even more in the home, you're seeing it, and you're seeing maybe multiple family members. So often the physician, when they go to the home, they're identifying a problem, but we have a large number of social workers who work with us here. Every physician is paired with a social worker, and they will be often someone who can follow up on many of the issues and referring them to other organizations. There are some great organizations here in New York that are out there to help, support groups for family members, or assistance with, referring them to different places to hire people, or transportation, or other things. So our social worker makes a lot of those connections. So it's certainly a team. I mean, all of geriatrics is a team effort, but certainly in this kind of work, I rely so much on my social workers.
What kinds of studies have you completed in your field?
Yeah, so I'm not a direct researcher. I do much more clinical work and program development, but we've recently done some of the analysis on our hospital at home program. So we know that patients are happier treated in the home. They like to be home. We know they actually have better outcomes than being in the hospital. Because if you go in the hospital, there's other infections you're exposed to. People get confused, especially patients with dementia. They get in the hospital and they're not in their own environment, and they get confused. Let's say in the middle of the night, they're confused, where am I again? And they get up and then they fall. So those are things that are less likely to happen at home, and we showed that in our work. And also, because of all of those things and others, they're less likely when they're discharged to have to come back to the hospital in the next 30 days. So those are some studies that we did in our hospital at home program.
Thank you. Do you think there's a correlation between human connection and wellness?
Oh, yes. Yeah. And that's something we actually are also thinking a little bit about, because in one way you could say, many of your patients are isolated. They're homebound, they're isolated. Yeah, they're going to have someone come in and check on them, but they don't have as many human connections. And so we do think quite a bit about that and try to see what are things that we can do for them. So one of the number one referrals that our social workers make are for kind of friendly visitors to patients' homes. There's also a great program here where people bring music to patients' homes. So professional musicians of all types, classical, opera, pop, everything, and they'll come into the patient's home and do mini concerts. So those are all community organizations that we try to now bring into someone's home, something that they can't, get out for, because we know that the human connection is important. It's actually important to preserve memory, right? So the brain is like the heart, right? You need to have exercise and then also human connection. Those conversations help preserve the brain function. It doesn't have to be crossword puzzles, those things. Those can be good if that's what you like to do, but if you don't like to do that, it's actually the conversations with people that help. If you don't use it, you lose it, right? So if you're not doing that every day and just watching TV, for example, and not actually having conversations, it can be detrimental to their cognitive function.
Now, what is the most rewarding part of your job?
Oh, that's a hard one. I would say two things. I chose to be here in an academic center because I love working with trainees. So I love bringing that medical student who's never done a home visit before, or a resident, and seeing that kind of aha moment for them. Probably they'll never go do this again, but they've at least gotten exposed to the idea, like, this is important, and some people do this, and maybe if I have a patient that needs this later on, I will look for a program that can do this for them. And then, it's the connections with the patients. I just love working with them and their family. Sometimes they have advanced dementia and are no longer verbal, but still can maybe smile, and it's the connection, that kind of connection are very rewarding. I mean, I can get into a world where I'm every day doing emails and meetings, and then it's like my day to go out on visits, and I'm like, oh, I'm so busy. I can't believe I have to go out. And inevitably I get to that first person's home, and I'm like, this is what I meant to do. I love doing this. And, I feel like I've helped someone in a real way on those home visits. So I love doing that.
That's so nice. I
Yeah.
actually always felt the same way when I was doing Sweet Readers, so it's
Yeah.
nice to hear about it too.
Yeah, exactly.
What do you think is the biggest, well, not biggest, just what do you think is a common misconception about elder care and Alzheimer's patients?
Yeah, I mean, I think one misconception is that, they have dementia, there's no point in communicating with them. And I think that people don't understand that there is a large spectrum to dementia. You can be forgetful but still able to function very well, and then you can, eventually you do become bedbound, potentially nonverbal, and you don't always know where someone is on that, and they may be in not in one place at any one time. So and even someone who's nonverbal, just touching them, and smiling at them, they can really recognize that innate ability of this person's being nice to me, they're not trying to hurt me. They can most likely still absorb that and respond with a smile. So I think that is a big misconception, because today we're often so isolated from, the general public is so isolated from people with dementia. And so if they haven't had the experience, they make assumptions. TV, when you see a TV show, right, they portray, the old lady with dementia, and then what you think is how everybody is. So.
Do you think there's enough awareness about dementia at the moment, or do you think that it could be better?
Oh, I think it could be better. Yeah. cancer is a very important disease to raise a lot of money on, and there's probably going to be more and more cures for it. But you see a million walkathons, marathons, whatever for cancer. Very important. But you see like 2 for dementia, right? And we're probably not as close to being able to cure things as all these new cancer treatments are. But if we don't try, we're never going to get there. And so I don't think there's enough awareness. I don't think there's enough fundraising. I don't think there's enough, I think people want to do the research, but there's just not enough funding to fund all the researchers and what they need to do. So I think we need more.